Well, this patient is progressing on ibrutinib, and now we are really going to delve into the question of sequencing. So curious what would be the standard of care for a patient under these circumstances, assuming that there is no evidence of transformation?
So I think if we truly think that this is CLL progression and then there is no evidence of transformation, I think the only prospective data, like we have talked about in one of the previous cases, is the data to suggest that venetoclax would be the treatment of choice in a situation like this. And I think that was a single arm phase 2 study with venetoclax as the only agent used. And although the complete response rate was about 9%, I think the patients who got on that study had a median PFS of over 12 to 18 months.
I think about 24.
24 months, which I think is reasonable. But again, I think this just tells us that if patients are progressing on ibrutinib, even the best treatment that we have now with venetoclax, we should be thinking about what next, particularly in our younger patients, because the expected benefit from venetoclax-based therapy is not going to be in the order of many, many years.
So what about combinations then, venetoclax plus rituximab, for example? Experience there, that patient population, and how do you decide ven as a mono continuous or to give in combination?
So I think that brings us to sort of the discussion point for the Murano study, which is the combination of venetoclax and rituximab compared to bendamustine and rituximab. So this was a randomized phase 3 study that was done to compare the treatment options for these two groups of patients. And this was in the relapsed setting, and it showed at the 4-year progression-free survival mark that the combination of venetoclax and rituximab did exceedingly well compared to bendamustine and rituximab. It's important to note that no patient who had ibrutinib prior to getting on this trial were allowed. So patients who were progressing on ibrutinib-based therapy were not eligible to participate in this study. So this is truly a patient population that has had progression on chemoimmunotherapy and went on the Murano study. And the combination of venetoclax and rituximab was far superior to bendamustine and rituximab. After a median follow-up of 22 months, the 24-month progression-free survival was 75% in patients who received venetoclax and rituximab. And over there was also a demonstrated overall survival benefit.
I think it's interesting, though, that patient population specifically really were completely BTK inhibitor naive patient population. So we have to keep that in mind when trying to extrapolate those data to this particular patient with resistance of disease. Another topic that it's a little bit off of our our agenda for discussion would be other emerging agents to sort of aid in this sequence. Thoughts on data from the ASH meeting. We're starting to delve into this area where we have non-covalent BTK inhibitors that could potentially address this question should this patient have had a CYS481 mutation, for example. You want to kind of summarize where, what information we saw at the ASH meeting? Because I think that is relevant, not to today, but might be a few years into the future.
Absolutely. So I think those are very exciting data that were presented at ASH with the non-covalent BTK inhibitors. There are at least 3 that I'm aware of. There's one by a company called Loxo. I think the agent is called Loxo 305. Thank you. The second one is an agent called ARQ531, and the third one is vecabrutinib. All these 3 trials have gone through, all these 3 agents have gone through their phase 1 dose escalation study and have found that all of these have reached potentially their maximum tolerated dose for the phase 2 portion of the study. And a number of these agents have shown significant efficacy in patients that have had both the BTK 481S mutation as well as in the wild type BTK protein, thereby suggesting that it would be these would be potential treatment options for patients like this one who are all progressing on ibrutinib-based therapy. And I know, Anthony, you had more data about the Loxo 305 study.
Yeah, we presented that data at the ASH meeting, but I think it's important, rather than even focusing on the individual agents, to just highlight that there is an emerging class present. I'm also curious a little bit about Richter's transformation because you mentioned this, and I know you guys have your center has most recently presented data on identifying these patients. You want to comment a little bit on the data that you presented at IWCLL on how do we identify a patient with Richter's who's progressing on a novel agent versus CLL?
So I think that's an important question because in the past, in the chemoimmunotherapy era, when we thought about Richter's transformation, we would typically do a PET scan to try and understand what the maximum SUV uptake was. And generally speaking, it was thought that if the maximum SUV uptake was less than 10, then it is less likely that the patient has experienced a Richter's transformation. And if the SUV uptake was greater than 10, it was thought that that lymph node should be biopsied to make sure it's truly Richter's transformation and not really an infection or a second malignancy. But I think in the context of BTK inhibitors, we've noticed that there has been a change where a number of patients with a maximum SUV uptake of between 5 and 10, and not necessarily only over 10, have also biopsy-proven Richter's transformation. And I think that just calls into question this threshold that we've used in the past, where we would say a threshold of 10 would be to consider a biopsy or not. I think we've now slightly revised our approach, where if we have a patient who we think is progressing on a BTK inhibitor-based therapy and we do a PET scan, even patients that have an SUV uptake of 7 or 8 on a lymph node, we are more inclined to biopsy these patients to ensure that there is no Richter's transformation.
I think it's a really important point. In the relapse refractory setting with an early progressor like this, we really need to make that distinction. I think these have been 4 really interesting cases that have been presented. I want to thank Dr. Ma, Dr. Parikh, and Dr. Patel for your thoughtful presentations and a lively, informative discussion. To our viewing audience, thank you for joining us for this Targeted Oncology Virtual Tumor Board presentation. We hope today's discussion was a valuable use of your time and you acquired some practical knowledge that you can take back to your clinic.